Okay, so hi, my name is Josh, and for my presentation, I decided to choose the small molecule drug Lorazepam, which I'll be doing my best to give a comprehensive overview on the drug itself, its synthesis, isolation, mechanism in the body, pharmacokinetic properties, some case studies on some assays that proved its effectiveness, societal and economic effects, and then some risks that come along with using it. So lorazepam is a benzodiazepine, and the specific IUPAC name is 7-chloro-5,2-chlorophenyl 3-hydroxy 1,3-dihydro-1,4 benzodiazepine 2,1. And as a benzodiazepine or a BZD, we've learned that it has calming properties since they target the GABA neuroreceptors and stop action potentials from firing. Crazy enough, lorazepam is used to manage conditions such as anxiety, insomnia, and seizures, and it also has some niche usages in sedating patients before surgical operations. The compound itself is branded under Ativan and Larive XR, and it was first synthesized in the US in 1977 by DJ Richards. The drug can be formulated into solid capsules for oral ingestion, but can also be dissolved into a liquid solution that can either be taken orally or injected intravenously. The synthesis of lorazepam begins with 2-amino 2'5-dichlorobenzophenone, which is then reacted with hydroxylamine to produce this intermediate right here, which is further reacted with this chloroacetyl chloride, and then this undergoes a heterocyclization to produce a 6-chloro-2-chlormethyl 4,2'-chlorophenyl quinozoline 3 oxide. Afterwards, this is then reacted with a methylamine, which leads to a rearrangement and a ring expansion, which forms 7-chloro-2-methylamino 5,2'-chlorophenyl 3H1 4-benzodiazepine 4 oxide, which has that diazepine ring right here that is characteristic of BZDs. The oxide is then reacted with acetic anhydride to undergo an acetylation reaction at the second nitrogen atom here, and this is quickly hydrolyzed by hydrochloric acid, which yields 7-chloro-5,2'-chlorophenyl 1,2-dihydro 3H14 benzodiazepine 2 on 4 oxide, and a further reaction of this with acetic anhydride allows for a Polanovsky type rearrangement to occur, which gives a 3-acetyloxated benzodiazepine 7-chloro-1,3-dihydro 3 acetoxy 5 2' chlorophenyl 2H benzodiazepine 2,1. And finally, a hydrolysis reaction occurs in the presence of sodium hydroxide, which forms our product lorazepam. After this synthetic reaction is completed, the drug must be isolated due to unreacted compounds or unwanted reagents in the reaction mix. And this occurs by cooling the reaction mix and then adding water or ethanol to the cooled mixture. And this encourages the crystallization of lorazepam out of the mixture. Afterwards, the crystals are then separated from the reaction mixture via vacuum filtration, and this removes many unwanted impurities, but you'd usually want to do a second or third round of isolation in order to keep the product as pure as possible. And this purification step is usually done by redissolving the crude product in a solvent. In this case, it's usually a hot alcohol solution and allowing it to cool. And after it cools, you allow the same crystallization steps and filtration steps to repeat. And after the product is purified as desired, the product is then dried in something like a vacuum oven, and this evaporates any trace liquid impurities from the crystals. And then afterwards, you have a pure product where it can then be formed into capsules or redissolved into a liquid form for IV or oral administration. As a BZD, lorazepam targets GABA receptors on neurons, but more specifically, it targets the GABA A receptors on GABAergic neurons. And this basically just means that it's the roughly 20% of neurons in the brain that contains these GABA receptors. GABA A is a ligand gated ion channel that, when activated, it allows for the transport of chlorine ions into the neuron. Lorazepam does not bind orthosterically, but it instead binds at a separate allosteric site, which is known as the BZD binding site. This BZD binding site, when bound, increases the binding affinity of GABA to its orthosteric receptor on GABA A, and this basically makes lorazepam a positive allosteric modulator of GABA A receptors. Just to recap, GABA is the neurotransmitter that binds to GABA A, and it binds orthosterically. GABA is considered to be an inhibitory neurotransmitter because of its ability to block signals in the brain, such as action potentials. And this inhibitory function basically allows it to produce a calming or sedative effect, mainly because if you don't have action potentials firing, then you're basically feeling more calm overall and you're not panicking or having anxieties or seizing. Yeah, and stuff like that. As I stated earlier, lorazepam is a positive allosteric modulator, meaning it acts as an allosteric agonist in this case. To be more specific, the mechanism of action in lorazepam is that when it's bound to the BZD binding site on GABA A, the binding affinity of GABA is increased. And so when GABA binds to its receptor, chlorine ions are released into the cell, and this produces the sedative effect that BZDs are known for by hyperpolarizing the inside of the cell, which prevents the inside charge of the cell from reaching a state where an action potential can be fired. Lorazepam further enhances this because of the binding affinity of GABA receptors. It's basically stronger. So when lorazepam or any other BZD is bound, GABA will stay bound longer because of that increased binding affinity. And this basically means the neuron will not fire an action potential for longer. And that just means that you'll get a more calming or sedative effect for a longer period of time. Figure 1 here shows the exact phenomenon I just talked about, where we can see that a normal action potential has a much higher peak versus an inhibited action potential when GABA is bound to these receptors on what was a dendrite cell. A study performed by Wang et al. In 2022 performed an assay in vitro to prove the effectiveness of lorazepam as well as other BZDs on their effectiveness as a positive allosteric modulator of GABA A. Um, Basically, what they did in the in vitro test was that they tested cells with GABA A receptors by first adding BZDs such as lorazepam and then observing the electrical signals in those cells to determine the calming effect that the BZDs had on the cell, as well as the percent modulation effect, which was just another way for to call the calming effect that was measured in the cells. Figure 2 demonstrates that all BZDs, including lorazepam, at specifically high doses, elicited calming effects in all trials. This proved that the positive modulation that lorazepam is claimed to have is true, but in order to prove the allosteric part, they went a step further. Just for some basic background, flumazenil is an active antagonist in GABA A receptors. So, in order to test the allosteric binding of the BZDs, flumazenil was added to the cells in the same way that the BZDs were added in the first test. And then afterwards, they just added the BZDs. Surprisingly, the same thing happened as seen in Figure 2. High doses of BZDs were still eliciting high calming effects across all trials, even in the presence of an orthosteric antagonist. This proves that in an in vitro study, lorazepam as well as other BZDs still have roles as positive allosteric modulators and elicit calming or sedative effects in these cells, even in the presence of antagonists. Again, Wang et al. Actually performed an in vivo assay in the same 2022 study, instead, this time using mice. Just to give some more background information, mice have what is known as a loss of righting reflex when they are heavily sedated, which means that they cannot upright themselves when flipped over under sedating conditions. This was used by researchers to conduct a loss of writing reflex test in mice, where two versions of it were run, one with just BZDs and the other with flumazenil and BZDs, basically for the same reasons of testing both positive modulations in GABA A and testing for allosteric activity. This time, they were looking to measure the latency to loss of writing reflex in mice, and the general setup of this behavioral experiment for the first test was just to inject the mice with BZDs and then flip them over on their backs and see how they responded. If they were sedated, then they would have a range of reactions ranging from a delayed loss of writing reflex, where they would regain it after a delay, to a complete and total loss of writing reflex, which signified total sedation and activation of GABA A receptors as a result. Um, in the first test, they found that the loss of writing reflex in BZD treated mice increased greatly with an increase of dosage, where higher dosages of BZD showed that the mice had a higher and higher delay before they would regain their writing reflexes. This proved that in vivo BZDs such as Lorazepam still have a positive modulating effect. And the same basically happened when they were injected with the antagonist flumazenil first, and then the BZDs. Um, you can see this in figure 3 as it shows the same trend where higher doses of BZDs still lead to a longer delay in the loss of writing reflexes, even in the presence of the antagonist, which again proves that even in vivo, BZDs like lorazepam still bind allosterically. Lorazepam has multiple different dosage levels due to it being able to be ingested either orally as a tablet, orally as a solution, intravenously, or intramuscularly. As a general rule of thumb, the dosages are divided based on age and are adjusted by healthcare providers, but usually the dosage is somewhere between 1 to 4 milligrams for most routes of administration. For some specific dosage values, for anxiety, the dosage will be around 2 to 3 milligrams orally and can be up to 2 to 3 times a day. For insomnia, due to anxiety or stress, the dosage can be around zero point 0.5 to 2 milligrams orally during bedtime, but will be around zero point 0.5 to 1 milligram for adults over 65 years old. When used as a premedication for anesthesia, lorazepam is administered intramuscularly between zero point 0.5 milligrams per kilogram to around 4 milligrams per kilogram around 2 hours before surgery. And for a serious condition such as status epilepticus, which is an emergency where a person is either having multiple seizures within 5 minutes or a seizure that lasts longer than 5 minutes, lorazepam is administered intravenously at a rate of around zero point 0.1 milligrams per kilogram up to 4 milligrams per kilogram with a max infusion rate of up to 2 milligrams per minute and will be repeated every 5 to 10 minutes if the patient is still seizing. For patients in the ICU who are basically heavily agitated, it's also administered intravenously at a rate of zero point zero 0.02 to zero point zero 0.04 milligrams per kilogram. And some other treatments that would have varying administration routes and therefore varying dosage levels include alcohol withdrawal syndrome, alcohol withdrawal delirium, chemotherapy associated nausea and vomiting, psychogenic catatonia, vertigo, and severe agitation. The mean half-life of lorazepam, or the T1 half in human plasma, is approximately between 10 to 12 hours, and this basically means that lorazepam is an intermediate acting BZD, and as a result, the duration of this drug's action is between 10 to 40 hours, and this is because lorazepam has a low lipid solubility, meaning it basically has a harder time crossing the blood-brain barrier, but after it passes and it's absorbed, it'll stay there and have a longer effect as a result. Moving on to Lipinski's rules. Just to recap, Lipinski's rules is a way to determine whether a compound would make an effective small molecule drug, where there's four criteria of a molecular weight: less than 500 grams per mole, a log P less than 5, less than 10 hydrogen bond acceptors, and less than 5 hydrogen bond donors. Lorazepam fits this criteria as it has a molecular weight of around 320 grams per mole, a log P of 2.4, 2 hydrogen bond donors, and 4 hydrogen bond acceptors. In terms of its administration, it is usually administered orally due to a high bioavailability of around 80 to 90%, meaning that lorazepam is absorbed much more efficiently if taken through the oral route, and it's usually absorbed in the gastrointestinal tract, and it can also be administered intravenously during status epilepticus as mentioned earlier, and can also be administered intramuscularly when routes of oral administration are unavailable, like before anesthesia. Quickly going over the distribution of lorazepam, it has a volume of distribution of around 1.3 liters per kilogram in adults, which suggests that the drug has a relatively deep tissue penetration. 91% of lorazepam is bound to plasma proteins, making them unusable. So the remaining unbound lorazepam passes through the blood-brain barrier via simple diffusion, but just remember that it takes longer to pass that blood-brain barrier due to that low lipid solubility. When metabolized, lorazepam undergoes both phase 1 and 2 metabolism, but it mainly undergoes phase 2 metabolism. And during phase 2, it is metabolized by cytochrome P450 isoenzymes, which basically conjugates it into a metabolite 3,0-phenolic glucuronide, otherwise known as lorazepam glucuronide, which you can see here on the right. This metabolite is basically inactive and it's just waste that's excreted by the kidneys. And this doesn't really have any problems passing through the loop of Henle, and it's not usually reabsorbed into the bloodstream through the renal vein. So in the end, lorazepam is usually just excreted as urine. Because lorazepam has a wide range of uses, as discussed previously, it's very easy for lorazepam to be overprescribed to patients that are suffering from one or more of these diseases. This can lead to a problem where patients are basically being overcharged much more than they should be because of an excess of lorazepam being given to them. Furthermore, it's extremely easy for this excess of lorazepam to lead users down a prolonged path where they'll develop an over reliance on the drug and can easily lead to misuse and abuse, which we'll talk about next slide. It's important to consider that while cheaper generics are also available on the market, there is an existing stigma on generics not being as good as brand name drugs, which is not necessarily always true. And as a result, people wouldn't save as much money as they should be because of their choices to be buying the brand name drug like Ativan over generics. Um, Also, using lorazepam obviously comes with the risk of hospitalization if misused, and this basically can just lead to hefty hospital bills that will quickly overshadow the cheaper costs of using lorazepam or any of its generics to treat whatever conditions the user was originally using them for. And finally, there's also the issue of stigma against those who sadly fall into a cycle of addiction with lorazepam, as they're usually viewed as like junkies or people that intentionally misuse the drug when in reality that's not always true. And some of them simply developed over reliances and psychological barriers due to the drug because of multiple conditions like anxiety and seizures causing them to overuse and misuse the drug. Lorazepam, like all other BZDs and drugs in general, has an inherent risk of leading to addiction, where a prolonged use of BZDs like lorazepam can lead to a decrease in GABA A receptors in GABAergic cells as a defense mechanism. This is just due to the constant presence of the drug in the case of a user that's misusing the drug. To just give it like a brief summarization of how tolerance works, and this leads to higher and higher doses of lorazepam being needed to reinforce the calming effect the user receives from taking the drug because of the lack of receptors for lorazepam and GABA to bind to. And in the end, when they inevitably run out of dosage, then they'll end up falling into severe withdrawals where some of these can be fatal if not treated correctly. And in addition, those that take lorazepam or other BZDs in conjunction with other sedatives such as alcohol um, will lead to basically overdose because multiple sedatives can work in conjunction with each other to slow down brain function enough by inhibiting action potentials from being sent. And this can slow down brain activity enough to slow down or completely stop vital functions such as breathing. And this is just basically an overdose, and it's easily fatal when left unattended to. And even if someone does not overdose on using BZDs like lorazepam in conjunction with other sedatives, an extreme amount of sedatives can easily impair judgment, and this can lead to poor decisions such as driving or some other dangerous activity that can easily become fatal. Okay, and finally, before I end, I just want to give a short recap of what we learned. Lorazepam is a class of BZDs, and it follows the mechanism of positive allosteric modulation of GABA A receptors in GABAergic cells. It's responsible for providing feelings of calm or sedation, and it's used medically to treat seizures, anxiety attacks, and insomnia, as well as other conditions. And it's been proven in vivo and in vitro to be an effective positive allosteric modulator. It can be administered in four different ways, being orally as a tablet, orally as a solution, intravenously, and intramuscularly. And each way has its own unique dosage and form of distribution throughout the body. But despite having multiple different administration routes, the drug is metabolized the same in the liver and is always metabolized into lorazepam glucuronide, which is urinated out as waste. And lorazepam has an inherent risk of getting addicted to it, as well as major impacts on societal and economic issues. Um, and it's important to understand the risks of BCDs as a whole in order to reduce the risk of overdose, and just basically know and understand what you're getting yourself into when you take lorazepam and other BCDs. So yeah, that's the end of the presentation. I hope you learned something, and please leave any feedback. Thank you.